All right, good afternoon. Those of you who are here, also those of you who are online. I'm trying to stand right in front of the camera so that those folks can see me too. My name is Gordon Hull. I'm the director of the Ethics Center here at UNC Charlotte, and I am very pleased to welcome you to the third of our talks on transplant ethics. This is a series sponsored in part by the NC Biotech Center and Dr. Olivia Kates, who's an assistant professor of medicine at Johns Hopkins, will be our speaker. Before I have Olivia come up and start talking, I want to mention that our fourth talk will be Dr. Ben Hippen, who's actually also here on March the 30th, is that right? March the 30th, it'll also be a lunchtime event. We'll also invite everybody here to come hear the talk. And if you can't make it, then you can also watch it online. So be on the lookout for stuff about that. I don't think I have anything else introductory I have to say, so I don't want to take time from Dr. Kates. So Olivia Kates.
Thank you. All right, howdy. Thank you guys so much for having me. I am Olivia Kates. I am an infectious disease doctor, so I take care of patients at Johns Hopkins Hospital. And then I also try to do research and work related to bioethics. And so I'm going to talk about something that I've worked on for a while now, which is a project dealing with vaccination requirements for people who are seeking an organ transplant. All righty. So I don't have any conflicts of interest, and I actually realized that this is probably the only venue I've spoken at where I might not have even needed to have this slide, but here it is. With that in mind, I'm going to give you guys a little bit of background before we get started. We're going to clarify the ethical question that I'm trying to answer, choose and justify a framework for analyzing it, and then we'll go through the whole analysis. I'm going to acknowledge a bunch of limitations, but if you think of other ones, I know Ben is working on it already, please interrupt and let me know, and then we'll wrap up. Okay, so some very rudimentary points about organ transplant first. Donor organs are scarce, right? Very scarce. About 10,000 people die every year. Either die on the waiting list or are removed from the waiting list for being too sick to transplant. Basically means we get them off the list before they die. The Organ Procurement and Transplantation Network, OPTN, is a public role created by the National Organ Transplantation Act in 1984. And the United Network for Organ Sharing, you may have heard of them, UNOS, is a private organization. They hold the OPTN contract to serve as the OPTN. So these are the guys that are in charge. Anybody else could actually bid for the OPTN contract and theoretically get it, just hasn't happened yet. So right now, UNOS is setting the rules for organ allocation among waitlisted candidates. They have an ethics committee. They endorse these various values, right? Utility, justice, respect for persons. Specific allocation criteria vary by the organ, right? Some are most likely to benefit, some are sickest first, some take into account waiting time, but the waitlist isn't sequential, so it's not lining up and taking your turn. People can move up and down on the list. New people can be added at the top. And sometimes the organ will go to someone further down on the list because it's a better match for that person or because it's part of a combo transplant. But UNOS does not identify candidates for transplants and does not add them to the waiting list. So transplant centers, hospitals like Johns Hopkins, screen patients and decide whether to list them for the transplant or not. The transplant centers are basically the facilitators and gatekeepers of the transplant waiting lists. UNOS and their ethics committee have put out some suggestions about general ideas that people should use for the selection process, but they don't regulate individual centers' policies. And so the individual centers have lots and lots of leeway. Okay, so now you understand all of transplant. Maybe you already understood that. Next, we'll do vaccines. And vaccines have a special role in transplantation. So first of all, if a transplant patient gets a vaccine preventable infection, it may be harder to recognize and diagnose because they present differently in people who are immunosuppressed. It may be more severe. It could cause the transplanted organ to fail or even cause the patient to die. It may be more difficult or more expensive to manage. We use a lot more medications in people who are immunosuppressed. They spend a lot more time in the hospital with these infections and may be more likely to mutate or spread to others. So vaccination has lots and lots of transplant-specific importance. But why does it have to be pre-transplant vaccination, right? Can we give people the benefit of the doubt, give them their transplant so they don't die, and then work with them afterwards to get them vaccinated? We absolutely could do that. That's not impossible, but there are some differences. after a transplant, vaccines may be less likely to work, and some are even unsafe to give, we think. And even if the vaccines can be given way down the line, it's this period right after the transplant, the early post-transplant period, where patients are the most vulnerable, where the vaccines are the least likely to work. In fact, in general, we don't even bother giving vaccines in the first few months after a transplant because we really don't think they're going to do anything, and where the transplant centers are under the most scrutiny for their outcomes from all of their transplants. So transplant-specific importance and time-sensitive. But a lot of people are not vaccinated. You probably knew that, right? As a nation, we all fall below CDC targets for every single vaccine and every single vaccine preventable illness. We flunk them all every year. This graph shows transplant patients and candidates specifically. This is not actually in the US. 75% did not get a flu shot in the preceding year. Most of them are actually talking about fear of injury and complications, especially injury and complications related to their transplant. But 9% of these people said that they refuse all vaccination. They are against them all in general. So although vaccination has transplant-specific importance, our transplant patients are not, immune to vaccine hesitancy, and they may even have transplant-specific reasons for refusing vaccination. All right, so clearly these slides are borrowed from another talk. It was my talk, so that's allowed. I had some technical difficulties when trying to change the template for these, so I gave up. But the point of these slides is to show that there are a lot of different barriers to vaccination. And really, these are the barriers to the good that we intend to accomplish with vaccination, right? We want to be preventing disease. So of course, no one's getting vaccinated if a vaccine doesn't exist. Some people may have things like allergies or medical contraindications, what I would call hard stops. But I put hard stops, right? Because often enough, there is a way to get around those. Some people will not be willing. Those are our volitional stops. That's most of what we think we're talking about today. But the biggest group, I guess after diseases for which there's no vaccine, which is a very, very large group, is this one. Patients who are totally willing and able to get vaccinated, but they just don't, right? Because the recommendations are confusing. It's really hard to get it all done. It's like 20 vaccines sometimes. It's not a top priority. They're not most worried about it. These are the soft stops. And then finally, even if we get the shots in the arms, in order to extract some good out of that, we really want these vaccines to work, right? These are our post-vaccination stops. So mandates don't solve a lot of those problems, but they probably operate here, right? They change some, but certainly not all minds, some of the volitional stops. And then because vaccination is time sensitive, they probably improve some vaccine efficacy by getting people vaccinated pre rather than post-transplant. But they have most of their impact on the soft stops, right? Convenience, priority, follow through, which I did say was a pretty big group. In fact, mandates are very, very good at mobilizing that group. This is a meta-analysis of many, many studies of healthcare worker flu vaccination policies, and hard mandates blow all of these other interventions out of the water, right? It makes sense. Hard mandates absolutely crush soft stops. Okay, so that's the landscape where we're proposing vaccine mandates for transplant candidates. And now I want to define the ethics question here. And this is, for me, probably the most important part of what I say every time I talk about this. I'm usually talking to an audience of healthcare professionals who are in the process of creating a mandate. We have to distinguish between what's right in the sense that it's like factually correct, what are our true statements, what's right in the sense that it's good, it's an ethical good that we want to have, what's right in the sense that it's fair, right, what should or should not be allowed, and then what's right in the sense that it's proper, that it's being done according to the best standards for our conduct. So when you hear people talk about vaccine requirements, think about where the evidence that they're giving you should actually be filed away, right? So maybe they're saying vaccine preventable illnesses cause a lot of problems in organ transplant recipients. That's a fact. I actually just said it to you. So, but that's just a statement of fact. And sometimes people find themselves arguing about the facts. What's this number? What's that number? Does it work, right? Maybe they're saying vaccination has a favorable balance of benefits and harms, right? That's a good. I hope you also believe that. I'm going to pass over to you again. Good facts and good, goods are important. We wouldn't want to mandate that someone do something that was either not smart or not good to do. But this information in itself is not a justification for imposing a mandate. And it's taken up a lot of the space in the debate about mandates, where people have not gone on to answer the next question. And then the last box, I think, is almost completely empty. But we're going to work on that question of fairness. So how do we know if something is fair, right? Ideally, everyone would get all the stuff that they need to flourish and thrive, but it's not possible, right? Some resources are limited and indivisible, like organs. Short of bringing everybody down to zero, right? Canceling transplants completely, some people are going to get treated differently from others. There are plenty of theories of justice out there. We got a wide spectrum. And I find that consequentialist thinking, so kind of utilitarian informed thinking, is pretty common in medicine, right? We're taught principle-based medical ethics. So we learn principles, beneficence, non-maleficence. Those always come first. Then they put autonomy, which we know about, and then they put justice last. Not sure about that decision. We're also taught a medical decision-making process that asks us to do almost the same thing, right? Forecast the likely benefits and harms from a treatment and choose the treatment that's going to have the most favorable balance of benefits and harms. So intuitively, those two thought processes seem like they're the same, and we end up applying this benefits and harms-based thought process to a lot of our ethical analyses too. In fact, I am guilty of that. This is a table from one of my papers, and it really talks about the expected harms from non-vaccination in transplantation. And it does it at a lot of different levels: recipients, other patients, the institutional environment, right, the hospital, the transplant program, and even the transplant organ itself. And the conclusion here is a defense of vaccine mandates that's based on these forecasted benefits and harms. Treating the graph here at the very end, at the community end of the spectrum, is actually a hint at where we're going with the next analysis. But I think there were a lot of problems with this one, right? I think this utilitarian or harms benefits justification for mandates has major flaws. And for me, actually, the last one on this list is the most important. It's subject to this absolutely torturous, constant recalculation with every single change in vaccine data and circumstances. Remember, and I'm not even just talking about COVID vaccines, right? This is where most people decided they wanted to do mandates, was COVID. But it could be any vaccine, and it could be any new data. It could be any change in population prevalence. It could be any change in the availability of treatments. These things changed day to day with COVID, and we had to reconsider every single day whether the justification for mandates still held up. That was exhausting. And so one of my recommendations today is, don't start with what feels like the punchiest justification for your position, right? Just because, you know, people are dying. That sounds very punchy, right? We want to stop people from dying. Very punchy. But when the data change, are you still going to want a mandate? And is your justification going to fall apart? So how can we get around all of that, right? Intuitively, I think we see some sort of social contract type reasoning in organ transplantation, right? So there's support organ donation because you never know if you or a loved one might be the one who needs an organ, right? That's kind of like a we're all in this together narrative. And we have the same thing in vaccination, right? Kind of like do your part to get vaccinated and protect the community. We're all in that together too. In both of these examples though, people who either need or have transplants are treated as the vulnerable members of the community. They're the ones in need of help. They need donated organs. They need you to get vaccinated from strong and healthy people who don't have to worry about that stuff as much for their own sakes. But we're going to use this exact same type of thinking to set burdensome expectations, like the expectation to be vaccinated for these people who are vulnerable, or transplant candidates. And the way that we're going to be able to do that is I'm going to cut all of the non-vulnerable people out of the equation by doing this. So all of our many social contract theories use either real or imagined negotiation among members of a society or group to elucidate rules and rights for that group. And what differs across the different theories is who is in the group and what are the conditions for the negotiation. So my argument is going to treat the transplant candidate patients on the waiting list, just themselves and nobody else, as a mini society subject to a social contract. I just get rid of all of the non-vulnerable people, the people we're usually saying you got to do this or that to protect the vulnerable. Now they're gone. Everyone who's left is vulnerable in just about the same way. And so now we can impose burdens on them. I'm going to justify doing that though, because it seems a little aggressive. I'm going to separate these patients out as a distinct group. And it's not just a medical group with common sort of characteristics. It is a relational group, a social group. I'm going to look at some of the empirical literature about the experiences of transplant patients. So not everything in the literature lines up with that, right? These are some common themes: guilt, indebtedness, duty to care for the transplant organ, an obligation, failure to fulfill that obligation if you have complications, and then this feeling of frustrated reciprocity because recipients are unable to repay the gift of the donor organ back to the donor, which leads to this last theme, right? Because they're unable to repay the gift back, there's a theme of perhaps paying it forward. And the specific examples that were given are starting support groups, promoting organ donation, like by being in commercials, and lobbying for policy changes that increase the number of available organs. And themes like this, right, indebtedness, reciprocity, are aligned with a prevailing discourse in transplantation. You have probably heard it, right, that deceased organ donation is a gift. The gifting discourse is deliberate, right? It started as a marketing campaign for organ donation. It does nice stuff. It elevates deceased donors and supports meaning making for donor families who have lost a loved one. I think those are good things, but it's also a little manipulative, right? It's been used even to push transplant patients to be more adherent to their medications and stuff by leveraging those feelings of indebtedness and guilt. And it's not the only option. So I'm going to introduce a recycling discourse that changes the nature of the relationship between the donor and the recipient, and between the recipient and their fellow candidates, right? So in the gifting discourse, the donor gives the heart as a gift to the recipient. The candidate community is totally passed over in that discourse. It's a one-to-one relationship between the donor and the recipient. The recipient then feels indebted to the donor, but of course, any desire to reciprocate is frustrated by the fact that the donor is not accessible. They are dead. In the recycling discourse, a donor gives up a heart that they can no longer use to be recycled. That recycled organ becomes a community resource, and the rules of that community place that heart with the recipient. In this discourse, there's no relationship between the recipient and the donor, and instead, the recipient may be looking back at the candidate community as the group of people from whom they extracted this scarce resource. And there are themes in the literature that align with this idea of a relationship between the candidate who gets an organ and the rest of the candidate community, right? So candidates may spend time defending their deservingness relative to other candidates, or some of them actually talk up the deservingness of others, express a lot of humility or even shame about their own deservingness by comparison. And recipients spend time giving justifications for their receipt of an organ relative to other candidates, right? I was the best candidate. Often this justification is, I was the only candidate that could take this one. And usually this comes in parallel with feelings of guilt, not guilt for desiring the death of their donor, but guilt for receiving an organ when others did not. And then I think we can really critique this paying it forward theme. It becomes more of a paying it back. The beneficiaries of all of these examples are not organ donors or families, they're waitlist candidates, right? In fact, one of the policy changes that recipients may advocate for is eliminating what's called family vetoes. Gets rid of the right of a deceased person's family to choose not to donate their organs if that person had registered as an organ donor. So these are recipients going after donor families in order to benefit candidates on the waiting list. All right. Hope you believe me about that. I'm proposing that the transplant waiting list can be treated as a mini society whose members are subject to a social contract, and so it is reasonable to impose burdens on them for the well-being of that entire community. And it's the impulse toward justification in particular that led me to this specific framework, which is Tim Scanlons Contractualism. We've had a lovely conversation about how invigorating it was to read the whole thing. I will teach you one of the most important things about Tim Scanlon. His initials are TM. They stand for Thomas Michael Scanlon, but he goes by Tim. So this was actually a big point of confusion for me when I was starting out. So it's not Tim for Timothy. And it's not Tim for weird pronunciation of TM. So Scanlon says that the basis for moral actions is the exact need to justify oneself to others in society, just like we said transplant candidates and recipients were doing within that society of the waitlist. Now, the terms for negotiation in Scanlon's theory work like this. We consider a proposed rule, and then we ask whether anyone in the society can reasonably object to it. And he wants us to consider all the objections at the individual level, right? So based on the burdens imposed on each individual, everyone's individual experience is equally important. Doesn't matter the number of individuals who are affected, right? So the idea is that you can't create a good society by imposing all of the burdens on one person and letting everybody else have a good time. A utilitarian might fall for that, but Scanlon would not. And then there are a few different types of objections that people might come up with. So it can be based on physical or material harm, right? This sucks for me, that I don't like it. It can be based on common sense morality. This one's a little tougher, but it's like the very idea of that turns my stomach. Or it can be based on disrespect or disregard. So it treats me as less than or differently from others, but for no reason. In order for the objection then to be reasonable, the objection has to be generic, meaning anyone else in my position would surely feel the same way, right? So I can't object for an individual or idiosyncratic reason, can't be eccentric. And the objection has to meet this greater burden principle. I can't object to flying down to Charlotte if the alternative was going to be to fly y'all up to Baltimore. And it's not because there's more of you, it's because even if there was just one of you, it's the exact same distance, it's the exact same burden. So they cancel out. I don't object though, by the way, I'm very happy to be here. But we do know people are going to object to our proposed vaccine requirement, right? It would not be a very good project if they didn't. They definitely do. These objections have two major flavors. A lot of them are about vaccination. And then the big one is about not getting the transplant, right? First, I'm going to address the ones about vaccination. So I'm not getting vaccinated because it's going to be harmful, because it conflicts with my personal philosophy, because I've been seeing all these sources saying that it's no good, because I don't trust vaccines because of things that have happened to me or people like me in the healthcare system. And then we'll talk about the objection based on denial of the transplant, right? And it doesn't matter why I'm not getting vaccinated. I object because now I'm not going to get my transplant, and because of that, I'm going to die. So first, the objection that vaccination is harmful. Actual harms of vaccination are pretty minimal, right? Sore arm, mild to moderate side effects. Minor burdens don't create a very strong objection. For most people, we think vaccination is a small burden. But remember, we're not worried about most people, right? We're worried about every individual equally. So what about the rare, serious side effects of vaccination, which I do not want to spend a lot of time talking about? I think we can overcome that exception pretty easily. The same rare effects are seen with and are in fact more likely with infection. So being non-vaccinated and causing infections to spread can impose the exact same burden on someone else. So rare side effects are not the greater burden. Then what about people with a serious medical contraindication to vaccination, right? People who we know going in, if we vaccinate them, are going to have a bad time, and then we make them get vaccinated anyway. That's a better objection, right? Now there's a component of disregard for their special circumstances, and we can make an alternative policy that doesn't impose that burden, right? We can create a medical exemption. This is another one that we can easily accommodate, right? So individuals with fulminant organ failure who would agree to get vaccinated, they technically could do that. They could try to get all of their shots, but at a huge opportunity cost, right? The process of getting vaccinated takes so long and the organ is failing so fast, they would have to die to comply with the vaccine requirement. That is a very big burden of harm that's associated with vaccination. So this approach, actually, the social contract theory, tries to balance burdens across members of the society. And I think it's doing a good job of illuminating exceptions that we intuitively thought were fair, right? If we were only talking about harms and benefits or about the consequences of a policy, all of these people might need to be treated exactly the same. They're walking around with the same risk for vaccine preventable illness, right? The same risk for losing that organ or for dying prematurely. But intuitively, we don't want to treat all of those people the same with our policy. Nobody wanted to make a policy that didn't allow medical exemptions for serious contraindications to vaccination. So when we instead focus on the burdens that are being imposed, we can see the difference between these groups of people. All right. A lot of people, most people in fact, are actually just physically safe getting vaccinated, but they might object for other reasons. So ignoring or being stubbornly against someone's preference not to be vaccinated is a form of disregard for their wishes, and we acknowledge that that could be a burden. But how serious a burden that is depends on the reason that they prefer not to be vaccinated. So like we said earlier, if that preference is individual or idiosyncratic, then it doesn't meet the genericness requirement. It's not the case that anyone in my position would feel the same way, so that's not a reasonable objection. But what if the preference has been created by pervasive, systematic misinformation, and there hasn't been any opportunity to get more accurate information, right? Then that objection might be generic. Any of us might come to a wrong conclusion if we only ever got wrong information. And I think we can try to overcome this with competing information, right? So that everyone has a sufficient opportunity to make a right decision. And those who are still unwilling are more like the individual and idiosyncratic objectors. And then what if the preference comes from personal, community, and historical experiences of mistreatment and exploitation, right? I think this objection is generic. We may not be able to imagine having those experiences, but it makes sense of the idea that those could lead to vaccine hesitancy or refusal in anyone. I think this is actually the hardest one to work around. It's not super palatable for people to build in an exemption for this reason, right? We handled all the other ones with exemptions. That was easy. This one doesn't feel quite right to make an exemption, although frankly, that would fix the problem. We can try to address these concerns, mostly about racism and anti-Black racism, through a variety of interventions in transplantation, right? So the opposite of disregard is regard, attention, consideration. So we could be trying to reduce inequities in transplantation in other spaces. We could be creating community-specific educational interventions or using community ambassadors. So we have opportunities to do better on this front. Maybe we can navigate this objection. And then finally, the denial of transplantation, right? We've seen this one happen. This last story actually is from North Carolina. And it says, North Carolina man turning down life-saving transplant over vaccine requirement. I have never seen this story expressed this way in any other news story. It's really surprising, right? All of the other ones, denied, candidate turning it down. Pretty cool. We're going to solve that one though with a visualization. It's pretty easy. Here are 3 transplant candidates. One of them is refusing to be vaccinated. I put him in red on the left. For the red-green colorblind, I've also included these little vaccine icons. The other 2 are happy to get their shots. Organs for transplant are scarce. Only have 2 organs to distribute among these 3 patients. And without a vaccine mandate, our 2 hearts may wind up like this, one to the non-vaccinated candidate and one to a vaccinated candidate. There they are. But with a vaccine mandate, they'll end up like this, both organs allocated to vaccinated candidate. So neither organ goes to waste. It's not a question of whether or not to perform transplants. It's a question of which patients should receive the essentially fixed number of transplants that can be performed. So this is our non-vaccinated candidate, and he's expressing his objection loudly, possibly on television, to the mandate. But this person, the vaccinated candidate who loses out without a mandate, does not get to be on the news. And they probably don't even know that the decision not to have a mandate cost them a heart and potentially cost them their life. It's pretty clear where that one's going, right? This objection does not satisfy the greater burden principle. It seems like it is a huge burden, but the exact same burden is imposed on someone else in the alternative case. There just aren't enough organs to go around, so these cancel out. Okay, but of course that means the green guy's objection to not having a mandate is also canceled out, right? So what objections to not having a mandate are left over? There's, I don't feel safe in a clinical environment with non-vaccinated people. We all go to the same clinic together. I could get an infection, right? I could get sick, I could die, or, I could just have the infection, not feel bad at all, be inactivated on the waiting list, not get a transplant if one's offered to me because they're afraid to give me the immunosuppressive medications. There's my transplant center's resources might be diverted away from me. Maybe their staff will get sick. Maybe just non-vaccinated people will get sick, right? And I won't, I'm vaccinated. But If there are enough non-vaccinated people who are sick who need to be hospitalized, especially if they're transplant recipients, they're likely to come back to their transplant center for this treatment. They may be hospitalized for a long time. The resources may be expensive. The transplant center may not be able to perform as many transplants. And again, I might lose out. And then there might be some objections related to this common sense morality. These are basically the things that were filed under the good in terms of ethical, not like good in terms of fair, right? I object because it's not courteous or because it's poor stewardship. I want to focus on those. And if some of that sounded far-fetched, right, it's important to know that vaccination and vaccine mandates specifically decrease the community disease incidence. It is harder to gather large-scale data like this, which I think is for Europe, for smaller communities like transplant candidates. But remember, we're not trying to use math to solve our problem, right? Concerns about vaccine preventable illness because others in your community or clinical environment are not vaccinated are biologically plausible. And in Scanlon's theory, it only takes one individual having this experience to have an objection. So I think these objections are valid. And I think they pass the threshold for reasonableness as long as we consider these events affecting one patient to impose a greater burden on them than getting vaccinated would impose on someone else. Remember, objecting about not getting the transplant is off the table. So we're only comparing this to burdens imposed by vaccination. These were the situations where we thought vaccination imposed a considerable burden. Medical contraindications and urgent transplants, we wrote exemptions. I didn't talk about these guys. I'm going to have to figure it out for some talks coming up in the spring and summer. But I don't think this framework is a great justification for mandates in children. I would give them an exemption here as well. And then lastly, our biggest and best objection that vaccine mandates might show disregard for earned mistrust in the healthcare system. And like I said, an exemption may not be palatable here, although I personally don't have any objections to that. And so instead, we would be looking at other ways to mitigate or manage this objection. They might be interventions to reduce inequities in transplantation or inequities in vaccination or vaccine acceptance. And then transplant centers should be looking at their specific population, trying to forecast the impact that these objections in particular might have if they were to implement a mandate. And some centers may not be ready for fair mandates before they do other legwork to earn trust in their communities. But here's where I landed in general. Transplant candidates can be considered as a society subject to a social contract that's going to impose reasonable burdens on individual candidates to achieve its purpose of promoting the well-being and fair treatment of all candidates. We took that society in an analysis based on Scanlons Contractualism. We considered various objections to vaccine mandates, and none of them persuasively caused us to reject our proposed mandate in every circumstance. So I think the mandate is ethically permissible as long as we're making appropriate effort to manage or accommodate those reasonable objections. And there are some advantages to this approach. It aligned with the qualitative data showing transplant patients feel that social group orientation. The choice of a social contract framework, and specifically the choice of Scanlon's framework, were informed by real data from real transplant patients. The framework accounts for the social and behavioral aspects of vaccination, not just the medical aspects, the sort of like do your part energy. It turns out when we ask people why they believe in mandates, the social and behavioral components are at the top of their list. It also accounts for those intuitive differences between those who won't be vaccinated and those who just can't. And for my sake, it is less contingent upon rapidly evolving statistics. As long as one candidate might take a hit, that candidate can express their individual objection. And I did try to center the perspectives of patients, right? We didn't talk about the transplant center being bummed out. We didn't talk too much about the broader community, although I'll acknowledge that all of these patients were hypothetical and I made them up myself. All right, so do you guys think that vaccine mandates for transplant candidates are right? I think it is fair for centers to impose mandates for patients for whom vaccination is not an unreasonable burden. But what can we be putting in this last box? For this, I actually spend like a little tiny bit of time on virtue theory as a way to examine sort of the procedural legitimacy here. We want to be conducting ourselves virtuously. We want to be showing patience, temperance, wisdom, transparency. And that might mean doing things differently from how we have done them so far. It might mean more due diligence before we roll out mandates, especially if they're going to seem unconsidered or ill-conceived. It might mean taking more responsibility for leading and creating other resources that promote vaccination. And it might mean spending some time on self-reflection before we act out of spite or anger. I'll say that although I think mandates are fair, I don't think that mandates have been created and imposed virtuously in every instance. A project I've been working on more recently is an interview-based analysis of centers' experiences with their mandates. And one of the things that I'm observing is there's a considerable misalignment between what people say or think their center's policy is, what the written policy document actually says, and then how the policy is generally employed in the center. That misalignment suggests to me that there have been some deficiencies in forethought and transparency during the creation of these policies, and that the resulting policies might not reflect the best of ourselves. All right, and this is a little jump to the side, but as my last word, I wanted to spotlight this, something I personally could do better on as well. I've been using this language of mistrust when really the actionable problem is trustworthiness. And I found this recent paper pretty cool. There is no normal level of trust. When I label communities as having low trust or high mistrust, I'm not making a comparison to some established norm of always trusting people, right? I'm making a comparison to the level of trust that I expect and experience with familiar, very accommodating, and generally majority white patients or research participants, right? And perhaps we could be thinking about this another way. Perhaps those participants are falling short of a norm for discernment, right? I don't know. But this is something where I hope to improve the language I use when talking about mandates, and I thought it might be interesting to you guys too. Whew. All right, actually, I am all set. Thank you guys for toughing this out with me. I really welcome your questions and especially your feedback. I won't get opportunities to do things like this that are really fun for me if they have not turned out to be useful or interesting to you. If we don't have time for everything, please do reach out for me online or via email. Thank you guys so much.
Thanks, Olivia. That was great. I noticed that you did not, unless I missed it, distinguish between deceased and living donation. Do you have the same recommendations for living donation where somebody could sort of opt out of that community through someone else they know?
Yeah, so that's interesting, right? So is a living donors organ a community resource, or is it really the resource of just the candidate who might be able to receive it? I think we should still be thinking about it as part of the community, even though that organ is not going to be allocated to anybody else. It affects the allocation of all of these other organs, right? So this is like a potential add-in. The problem is that gives us the opposite justification, right? Now it is a decision of whether or not to add an organ in for the whole community, not just for that one person. So I think we're going to have a hard time enforcing mandates using this justification for people who have living donors. We're going to come up with a new one though, because there's a big equity problem there, right? People who have access to living donors are generally advantaged people with really strong social networks. They're usually white. And so we're going to be creating an equity problem by pulling people out of our community and leaving a specific group of candidates behind to struggle for the same scarce resource.
Thanks for your talk. So this may be my misunderstanding of how the transplant list works, but I'm wondering about the urgency thing and the difference between urgency and the fact that I presume people that have to spend more time getting vaccinated before they can be eligible for a transplant being kind of disadvantaged just by how long it takes, right? So the motivation for the question is something like, if certain communities are generally unvaccinated compared to other communities, then they'll have to wait long because you have to get all the vaccines, right? And isn't that bad for their outcomes? And isn't that a generic objection?
Yeah, so our people are starting this race at a different place, right? Some people are showing up to the vaccination race super duper vaccinated, and some are showing up not super duper vaccinated. This kind of gets into the details of how you create and implement these policies, right? So if someone needs to finish their race to get their transplant immediately, That's the urgent transplants. And that's where I think the policy is not going to work out because it's not going to be fair. But if someone needs to finish their race to get in another race, I don't think we have a problem. We can manage the lists by adding them to the list, but having them be inactive or internally inactive. We won't actually accept an organ offer for that patient, but they can accrue wait time while they're going through the process of getting vaccinated. If they reach a point where their transplant becomes urgent, our policy no longer applies, and then they can have their transplant.
I guess I still feel like there might be like a correlation between how long you spend and how good your outcome is when you get, because presumably,
Yeah, there is.
Between,
true.
Between two groups that both have non-urgent needs for transplants, if one of them tends to get transplants earlier, presumably that's good for them, right? So no urgency involved at all, but just.
Yes, that is true. But the average amount of time that these candidates spend, in particular like on the kidney transplant waiting list, for example, far exceeds the amount of time it would take to get most of these vaccinations. And so a practical consideration would be, how many do we mandate? And do we mandate the ones you have to get like 6 months apart? Or do we create sort of a schedule for people that gets them all the way caught up within 6 months when they're going to spend the next like 2 to 5 years on the waiting list? Yeah, no problem.
Thanks. So I have I'm trying to think about this fair and proper and the boundary between them, because it seems like there's probably some traffic across that boundary in the case of underserved or minority communities, right? So is it fair to impose a mandate on a Black community that remembers Tuskegee? That's one way to phrase the same, but another way to phrase the same question is, particularly because the research says that good outreach helps with vaccine acceptance, is that really a question of doing it the proper way and doing it virtuously?
Yeah, I think there's actually bleed through across every single one of those boundaries, right? None of them bleed backwards to make facts not true, I hope. But, right, we use facts and then we pull them into our, is vaccination a good? And then we pull that over into our, is a mandate fair? And then we are dragging a lot of that material over yet again into that sort of space of what's proper. They're just two totally appropriate and relevant ways to articulate the same idea, right? Is the mandate fair when it imposes unequal burdens or shows disregard, right? Disregard's inherent in the way the mandate is created. Or is the implementation of the mandate proper if it is a reflection of racism in us, right? That, not super virtuous, falls under this proper category. I don't think it's necessary that every idea only be expressed in one space.
Great talk. I have a question for you about the social contract framework as you use it and generally speaking.
Woo.
So, right. Start small, right?
Please.
So, one of the challenges with social contract theory in general is that most of them are idealized theories of a social contract. In particular, you invite us to imagine a community of potential transplant recipients that are a community.
Yes.
But they didn't choose to be in that community. They didn't sign a contract. They were in many ways enlisted or indentured into that community.
As were we all into ours.
Well, although that's part of the issue with the idealized feature of most social contract theories, which is that they invite us to cleave off a number of aspects of our individual identities that have a history and a context and focus more on others. I bring that up because in the initial part of your talk where you reviewed some of the utilitarian considerations, and in particular, the point about uncertainties about the efficacy of vaccines and how that tends to ebb and shift over time, both in terms of how the community, herd immunity evolves, as well as our evolving empirical understanding of how well these vaccines work or don't work in certain types of circumstances. And that is figuring out that risk calculation is, as you said, very, very difficult. But the messiness of non-ideal theory, the messiness of taking into account history and context and lived experience, in many ways is a more authentic capture of the moral claims that individuals have on us as transplant professionals or on transplant centers as those in authority to have the opportunity to decide who does and doesn't get a transplant within certain rules. I think the worry here is that a social contract framework that is ideal in this way ends up losing legitimacy to the extent that it doesn't take into account these non-ideal features, which you start to talk about toward the end. And in fact, in fairness, you really draw lines through all the way through. So that's a very long throat clearing way of asking you, is a social contract model as useful as, say, a model that I argued for when you and I had this conversation 6 months ago, which is that it's just a brute political fact that the state allocates authority to transplant centers for who gets organs and who doesn't get organs within a framework of rules. But they have that authority because they have the ultimate responsibility for the outcomes. That's not really social contract theory. It may be a contract between the state and transplant centers, but it's not a social contract theory in the sense of, in the Scanlonian sense, what we owe to each other. So why do you like that version, that Scanlon version, versus the this is just how authority is allocated? And you can challenge it if you don't like it, but that's really the basis of why transplant centers can impose mandates or not.
Yeah, great series of questions. I did try to build in a little bit of that lived experience-based legitimacy by drawing on some of the qualitative literature, but I acknowledge there's a gap between real transplant candidates and the hypothetical candidates that I've used to sort of simulate this negotiation. That said, I think these are the realities of authority. Actually spends less time incorporating the lived experiences of real transplant candidates, right? This is now a top-down message, whereas this is a hypothetical and faked bottom, but bottom-up analysis. And so I think there's an advantage there. I also think, and this is another thing that's important to me, I don't want to base any aspect of my argument on a concept, a narrative, or a framework, or foundation that I want to also dismantle, right? And so I didn't want to make an argument based on the gifting discourse. It's been done, right? People will say, these people, they owe something to those donors, right? It's just not fair to the donors that they won't choose to be vaccinated, but they're going to take that person's organ. I'm not going to do that because I don't want the gifting discourse to hang around forever. I think the recycling discourse is better. I think it creates a context in which we can say that being a donor is now a norm or expectation, and deviating from that norm is problematic. Whereas, a gift is like, that's really nice. So I don't want to start from a foundation that I think has problems and is going to require me to hold on to those problems and carry them through to keep my justification going forever. So I tried to do something that was linked up with recycling, qualitative research, did my best. Thank you.
Thanks. Do you have any sense legally of how religious objections might play with this kind of a policy?
I am not an attorney, so please do not interpret my remarks as legal advice. However, I think that the clinical judgment leeway that transplant centers have in selecting candidates is extensive. And I think that it is possible to overcome objections even of that nature. I actually think some people have written that they believe that that could happen. I actually have not seen litigation related to religious freedoms, though. I've seen litigation related to personal freedoms. And so far, in the instances that I'm aware of, those suits have been unsuccessful in overturning the mandates.
Questions as well. No one else does. So I thought a lot of the arguments you made would also support a US government imposed countrywide vaccine mandate.
I thought the same as well,
So,
Trevor.
I wanted to hear more about that.
Yeah. So the reason I didn't give that presentation is, first of all, I value my life. No, well, I do, but it's not the space in which I primarily operate. It is an argument that's already been made. People have written that paper. It didn't result in government imposed mandates. It didn't happen. And so I don't think that there's a pragmatic benefit to continuing to prioritize that argument. But I did think that there's a pragmatic benefit as centers try to actually make decisions in real time about mandates to formulating this argument.
Because the centers are private companies and therefore have less.
They still have some political things to worry about. In fact, some of the rationale for not wanting mandates, because not everybody did it, and some of the rationale for not wanting it was fear of backlash. And my interviews with people who worked at centers that did have mandates, backlash did in fact occur, and it was often misdirected. The sources and targets of the backlash were unexpected. So it was mostly backlash from the public, not from candidates. And it was mostly targeted at the people they could access, which is unfortunately our nurses and nurse coordinators who answer the phones, but who did not create or impose the mandates. Many of whom, in fact, might share some of the concerns that the people calling them feel, but they're the ones who are on the receiving end of what could be a lot of vitriol. So they do still have these political considerations, but I think that the leeway that they have to impose sort of their clinical judgment is sufficient to empower them to do this. And so they were doing it. I thought it was really important actually to understand a justification for doing it. That differed a little bit from what people came up with automatically, you know?
Okay, so great talk, by the way. Earlier you mentioned this idea of social networks being predominantly like white communities having this kind of social network to access transplants more easily. So I guess my question is really just how is social networks and connections valued in the policy of transplant? Because I don't know a ton about that. And how does that play into minority communities and maybe urgency?
Yeah, this is a really good question. Thank you, Kaylee. So social networks are a really big part of transplant and transplant ethics. In fact, one of the other criteria that transplant centers use to assess a candidate's sort of qualifications or readiness for transplant is their social connectedness or social support. Because transplant is really difficult and people can't usually sustain going through the transplant process alone, they need help. We assess how much help they have. The resources that people have to help them vary by people's social status, situations, and experiences of structural injustice. There's a lot of work out there about whether social support criteria are in fact problematic and that problem could be fixed by eliminating them. Something I think is interesting about this justification for vaccine mandates actually is that it does not provide a good justification for some of the other criteria that we use. It does not provide a good justification for social support criteria, which does not have any transplant-specific community externalities, right? You can't catch poor social support from another patient in the clinic. It does not provide a justification for abstinence criteria from smoking or from drinking alcohol, because again, those do not have transplant-specific negative externalities. I like that about this too, right? Sometimes people would say, oh, you know, we make people quit smoking. That's hard. Let's just make them get vaccinated. That's easy. I don't like that justification because again, I don't want to build my justification on something that I think is problematic and that I don't want to continue into the future. So to very rudimentarily begin to answer your question, social connectedness is a huge deal in transplant, and we have not worked out how to make that fair.
Thank you.
Yeah.
So I think I need a rudimentary explanation here, because in the back of my head was this sort of like, okay, if I'm a transplant patient on the waiting list, suppose a mandate comes down that transplant patients improve their fitness level or improve their diet. And it
You're
seems
going
to
to
me
want
that-
one though with externalities. So what about transplant patients must have been a donor, registered as a donor, because that has transplant specific externalities.
Right. So why does the contractualist justification not give me, as a transplant patient who has signed up to be a donor, a very good reason to object to those who have not? In other words, how does this not justify a mandate in these other cases, which it sounds like you want to back away from?
That's right. I don't want to use this as a justification. And I'm only going to say about things with externalities, right? I don't think or want it to be applied as a justification for things without those externalities, right? It has to hurt one other guy in order for there to be an objection. But for the things that do have externalities, I would say that there is a timeline problem with the I was registered to be a donor issue. You can't like become an organ donor while you need an organ. Yeah, it's not super relevant per se to do that. And so that is judging people for a past behavior when they were not a member or trying to become a member of this community. So they had no expectation that they would be subject to the rules of this community. If we had a bigger rule, right, like Trevor was saying earlier, then they would have that expectation that they'd be subject to that rule. But we don't really have that right now. So my thought is that since the decision that they made about this was made when they were not either applying to or in this community, that it should not be judged as
Okay.
a rule for this community.
So let me push a little bit more. How about stop smoking and improve your cardio health rule? So I joined the transplant list and like, all right, look, you need to get vaccinated and you need to start working on your cardio fitness. So the graphic of the three people who want the two hearts,
Yeah,
one of them gets left out. And in the case where the one who's left out with somebody who got their vaccines, they have a legitimate complaint that the donor likely was wasted on the person, or the heart was wasted on the person whose outcomes were worse because they didn't get the vaccine.
that's not really the nature of their complaint.
So I think I
Right.
misunderstood their complaint though.
Yeah, so they do have a complaint about not getting the organ, but that complaint doesn't carry forward to become a justification for the mandate because it's canceled out by the other guy's equal complaint, right? We do it this way, this guy doesn't get it. We do it this way, guy doesn't get it. No greater burden, they're equal. So those are canceled out. And so the objections are all the green guy, right?
Right.
The vaccinated candidates' objections are all based on the externalities that they experience because of non-vaccinated candidates. So it's totally dependent on having those externalities, not the stewardship argument, not the waste argument, but the externalities.
So I'm being too consequentialist. Is that the?
You're
short
being a little
answer? Okay.
consequentialist, yeah.
Okay, just make sure what I'm doing. Okay, that's helpful.
You're doing it. And that's how they do justify making people improve their fitness, which we literally do, and making people stop smoking, which we also literally try to do.
I have a question from the Zoom chat.
Awesome, thanks.
Bill Brandon asks, would your argument about mandates for vaccination also apply to harvesting viable organs in the case of deceased individuals with appropriate religious and other exemptions? He says you've already dismissed the gift arguments.
Yeah, I think that although the narrow social contract argument that's specific to the candidate community probably wouldn't work well to talk more broadly about organs from deceased individuals, the recycling discourse that informed this argument does kind of work for that, right? So if recycling becomes an expected norm, and we have youths here, right? You guys are probably really good at recycling. You might even compost, right? That norm is being created. That's something that we are going to come to believe is a reasonable expectation of everybody. Now, if transplantation is also a recycling process, then that should be a reasonable expectation of everybody as well, right? So there are a lot of countries in the world who use opt-out donor status. And that's kind of like what you're describing, Bill Brennan, right? We would harvest or procure organs from deceased individuals who had not specifically said they do not want to be a donor, and that would usually be for a religious reason. We don't do that here, but they do it in Spain. They get way more donor organs than we do. It's actually pretty awesome. They've been doing it for more than a decade. They love that policy. And maybe if we spend more time thinking about recycling and less time thinking about gifting, we'll end up doing that too.
All right. Unless there's one last question, we've hit our time. So I think we can thank